Hello, and thanks so much for joining this webinar, Oral Mucosal Premalignant Diseases and Squamous Cell Carcinoma. To start, we'd like to welcome you to the Colgate Oral Health Network, which is celebrating a decade of professional enrichment this year. We are proud to commemorate our 10-year anniversary as your dental team's one-stop resource for free dental continuing education. We are also excited to see that we have an international audience in attendance today. On the left, you will find a chat area which is dedicated to relevant questions and comments concerning the subject matter only. So please continue to type all of your questions during the lecture in the Q&A box on the left of the screen, and they will be addressed by our experts during the interactive session. First, it's my sincere pleasure to introduce you to Dr. Ira Lamster, who is currently Dean Emeritus at Columbia University College of Dental Medicine and professor at the Department of Health Policy and Management at Mailman School of Public Health. His research efforts have focused on diagnostic testing and risk assessment for periodontal disease, the interrelationship of periodontal disease and systemic disease, the oral health care needs of older adults, and the future of dental education and practice. Dr. Lamster is joined today by Dr. James Sciubba, who has an active clinical practice in oral medicine in Towson, Maryland, and has served at the M.J. Dance Head and Neck Center as the clinical consultant. He has published broadly with over 225 peer-reviewed papers and abstracts, plus he has authored, co-authored, and edited 7 textbooks. He has lectured worldwide and is co-founder and current president of SPUNK, a large national support group for those with oral and head and neck cancer. We would like to thank Colgate for providing an educational grant that makes this lecture possible. And without any further delay, please allow me to turn it over to the experts themselves. Thank you.
I want to welcome everyone to this evening's webinar, which is entitled Oral Mucosal Diseases and Squamous Cell Carcinoma. Oral squamous cell carcinoma accounts for approximately 4% of U.S. cancer diagnoses, with nearly 50,000 new cases each year. It also accounts for nearly 11,000 deaths in the United States on an annual basis. However, only 40% of cases are diagnosed at an early stage, and it is recognized that early diagnosis is associated with greatly improved outcomes. At present, the 5-year survival is just over 50%, a percentage that has not appreciably changed in decades. So, early identification is key, and familiarity with the clinical precursor lesions is essential. Therefore, understanding and identifying premalignant and malignant oral lesions remains a challenge for the dental profession. To provide an in-depth review of this topic, our speaker this evening is James Sciubba. Following a 16-year tenure as chair of dentistry at Long Island Jewish Medical Center, Dr. Sciubba was recruited as professor in the departments of otolaryngology, head and neck surgery, pathology and dermatology within the Johns Hopkins School of Medicine, where he served as director of dental and oral medicine until recently. Jim is an active clinician and educator and is published broadly, with over 225 peer-reviewed papers and abstracts. Plus, he has authored, co-authored, and edited 7 textbooks, including the very well-known textbook of oral pathology. Jim is past president of the American Academy of Oral and Maxillofacial Pathology, was the oral pathology section editor of OOO, and served as associate editor of the Journal of Oral Medicine and Pathology. I cannot think of anyone who is more qualified to review oral mucosal diseases and squamous cell carcinoma than Jim Sciubba, and it's really a pleasure for me to introduce him. Jim?
Ira, thank you very much for the kind introduction. The numbers you gave, I think, are very important, but I can say optimistically that some of those numbers have shifted based upon the most recent data I've seen from the SEER databases. So that 50% survival rate has actually gone up to a little bit over 60%. So we are making headway for lots of reasons, and hopefully we'll be able to discuss those. But for now, I would like to walk you through a plethora of lesions in the oral cavity, from benign to premalignant, and then of course to frankly malignant, and discuss a little bit about the biology, about some of the more recent advances and some of the aspects of molecular genetics and so-called liquid biopsies and so on. So we'll see where this goes. It's a very deep subject and very, very fascinating, and that it just never ends. So let's get into this, and I will try to illustrate my teaching slides with illustrations from clinical photographs of patients of mine that I've seen over the recent past, just to amplify some of these concepts. So here's what we're going to do. We'll start with non-leukoplakia white lesions, and there are many of them, which I'll show you. Then we'll be talking about leukoplakia, extending to epithelial dysplasia. A separate variant of leukoplakia called proliferative verrucous leukoplakia is a very special type of a condition with interesting pathology and behavioral characteristics. My favorite, lichen planus, which I see a lot of clinically, and does have premalignant connotations, ranging from 0.5 to 1.5, 2.5, 3.5%, depending upon what you read in the literature. Erythroplakia, submucous fibrosis, a relatively circumscribed type of alteration found predominantly in Southeast Asia, and of course, oral epithelial dysplasia. Speaking of cancer, squamous cell carcinoma, we'll talk about various stages and how we stage these lesions, how they behave stage per stage, and what the survival statistics happen to be based upon staging criteria. Toward the end of the presentation, I will show you some work that has been done now over a decade ago, which allows us to understand how these premalignant lesions or even benign states go into premalignancy and frankly to malignancy based upon some very elegant chromosomal and genetic studies done at various institutions, including Mass General, Johns Hopkins, and many others. Then we'll talk about diagnostics currently available and what has been available from a classic standpoint and where we may be going in the near future. So let's talk about lesions that are white, but they're not leukoplakias. For instance, this is typically white. It's a classic reticular type of oral lichen planus. You can see these branching, arborizing, and merging white lines. These are striae, and that's classic reticular lichen planus. This is also lichen planus, but you don't, on the tongue, on the dorsum of the tongue, you don't see that reticular quality. You see more plaques and homogeneous alterations with papillary alterations. This is a white lesion, but this is candidiasis in a patient that's had antibiotic therapy for C. difficile infection. This is tobacco pouch or snuff dipper's keratosis. This fellow would take a small pinch of tobacco, or maybe not so small, and put it in the buccal sulcus adjacent to the cheek and have it sit there many hours a day. He would change it often. And over time, you develop these furrowed white areas that are ultimately reversible if you can get these patients to stop this habit of snuff dipping. This is by far the most common white lesion. This is traumatic keratosis based upon either habit or functional considerations. Here you can see a linear band of thickened, benign keratotic alteration surrounded by essentially normal mucosa. This is another white lesion of the hereditary type of keratotic disorders. This happens to be white sponge nevus, but if I told you it wasn't, the alternative diagnosis could well be hereditary benign intraepithelial disc keratosis, HBID, or even disc keratosis congenita, but totally benign and irreversible, and these are genetic in origin. This, unfortunately, is called hairy leukoplakia, a photograph I took back in the early 80s before we had any idea of what HIV disease was, and we were beginning to define what AIDS was. But this was a classic demonstration of the patient who was immunosuppressed with these lesions on the lateral border of the tongue called hairy leukoplakia. In fact, it's got nothing to do with hair. It's got nothing to do with leukoplakia, really. It is basically an EBV viral infection of the epithelial cells. That's hairy leukoplakia. But let's get into leukoplakia, because this is the most common white lesion we're going to see and talk about it. you can have a choice of any of the definitions out there. There are many of them, most of which are confusing, and a lot of them represent contradiction, gobbledygook, and it's difficult for me to follow. I happen to like this one. It's already 13 years old or so. White plaques of questionable risk, having excluded other known diseases or disorders that carry no increased risk for cancer. Okay, so you ruled out these other white things, as it were. There have been many, many definitional changes until this very year. A paper I saw just recently from the Dental Research Journal offers this dubious definition: predominantly white, irreversible, non-scrapable, usually associated with tobacco, betel quid, ethanol, and may also be idiopathic in nature, which is one of the greatest concerns we have, those that arise in the absence of habits. Here we go. Anterior oral floor, a white discrete patch in a patient that may or may not have had tobacco alcohol habits. It's a bad place for leukoplakia to occur because the risk of transformation here is relatively high compared to, let's say, the buccal mucosa. Well-defined, homogeneous in this case. Now, here I put a circle in around the more subtle one, but this area here, this leukoplakia, it's a white patch, cannot be removed, cannot scrape it. I can't tell you what it is, but look immediately adjacent to it. This is far more concerning because it's granular. It does have a white component to it, and it's got a red component. So this may be called by some speckled leukoplakia or erythroleukoplakia, far more dangerous than homogeneous leukoplakia. Homogeneous leukoplakia, but widespread, involving the alveolus sulcus and the attached gingiva in the denture wearer, but extensive. This alteration in the buccal mucosa extending into the alveolus sulcus is somewhat granular to warty, and this is an early phase of something called proliferative verrucous leukoplakia, which we will talk about subsequently. So those are some variations on the theme of different forms of leukoplakia. There are infinite varieties of it, but just a taste of what these could be. Now, what happens when some of these leukoplakias or white lesions or mucosal lesions are deemed to represent something that is pre-malignant or have dysplasia present? Dysplasia is the tissue characteristic, and dysplasia are composed of atypical cells which form a tissue which is dysplastic. And we know that various degrees of dysplasia hold a risk for transformation into cancer. And that risk generally tracks along with the severity of the dysplasia. But degree of dysplasia alone does not correlate with clinical course. So you've got to keep that in mind at all times. If you identify dysplasia by virtue of a biopsy, it doesn't mean that their patient is condemned to cancer or is going to carry that as a benign lesion forever. So follow-up is important, which we will talk about. And importantly, lesions of the oral mucosa, which are non-dysplastic at the time of initial diagnosis, they can eventually become dysplastic and transform into cancer. The dilemma, another dilemma, no single molecular pathway is known to serve as a primary risk factor for recurrence or transformation. It's a very, very complicated system of pathways and, importantly, networks composed of pathways. Important in all of this is the P53 focus, where mutations at this particular locus, in particular at resection margins, may predict recurrence, even though there is not evidence of dysplasia in the presence of P53 mutations. So how do we deal with leukoplakia? How do you manage it? First of all, and key, is establish a histological baseline. And by gold standards and by tradition, a tissue biopsy, a scalpel biopsy, a punch biopsy, critical to have that in your armamentarium or refer out to someone who does them on a routine basis. You assume a benign diagnosis until it is proven otherwise. So these can be removed with a scalpel. They can be lasered off, CO2 laser in particular, and others. Photodynamic therapy with administration of particular photosensitizers, and cryotherapy, the latter two not used all that frequently in the oral cavity. But there's no real good consensus as to what is the most appropriate treatment. They all have their strong points and weak points. So what are margins? What about them? How close should you get to the interface between the pathology and normal mucosa. 1 millimeter, 3 millimeters more. It also depends upon the training of the surgeons involved. But more recent studies have shown that 3 millimeters is adequate to define margins and safety. So behavior. The recurrence of leukoplakia shows a very wide range, 7% to over 35%, almost 40%. The latter, I think, is a bit of an overkill, but nevertheless, they're published numbers, and we relate back to that and refer to it. So what factors are important in the transformation of these leukoplakias? Well, what type of leukoplakia? Homogeneous, thick? Is there a red component? Where is it? Is it on the top of the dorsum of the tongue? Is it in the floor of the mouth? Is it on the buccal mucosa? All of those have a role in determining what the risk of transformation might be. And of course, what is the grade of the dysplasia being identified by the pathologist on the tissue that you submit to them? Is the patient a smoker? Do they consume alcohol? Now, these are important, but they are not necessarily critical, because many of these dysplasias can transform in the absence of smoking, in the absence of alcohol abuse or use even. And an interesting question that is by no means a new one, but is achieving more and more relevance and importance, concerns the presence of long-term, low-grade chronic inflammation. Periodontal disease, is that a factor? Chronic trauma, is that a factor? And there are some good studies implicating these two possibilities as being important from an etiologic standpoint. Let's talk about PVL. This is a very important subset of leukoplakias, defined in 1985 by Lou Hansen and colleagues at UCSF and Bud Silverman and others that we know. Is it a cause for confusion? Well, if you don't know about it, you will be confused, but I'll hopefully go over what makes this special, and it shouldn't be confusing. Is it real? Yes, it is. You bet your life it is. I've got many patients in my practice currently active with PVL and others that have been treated in the past for it. And what makes it special, you'll see. This gentleman I continue to see. He lives in southern Pennsylvania, comes down to see us periodically. You can see that he's got thickened keratotic lesions involving the attached to gingiva, which do not extend into the alveolar gingiva and occur on either side of the midline. Also on the palatal aspect, extending into proximally. I biopsied an area. Let me show you if I can find out. Yeah, this area was biopsied by me right up in here. It was a bit nodular. It was concerning, so we biopsied it. And this is what it looked like. You can see it looks a bit warty. It's certainly proliferative. The epithelial ridges are extended. Lots and lots of chronic inflammation, which is chiefly lymphocytic in nature. But in other areas, you see dyskeratosis, the presence of prematurely keratinizing cells deep in the surface epithelium, but tends to be restricted to the epithelium. This is not, in this particular image, not gone beyond the epithelium and extended into the connective tissue or the lamina propria. So this is moderate to severe dysplasia with dyskeratosis, something that has got to be dealt with, and it was. So in the past, this entity was known as oral florid papillomatosis, in particular in the dermatology literature. Now, generally speaking, I'll show you some cases. They start out as flat and solitary, but over time, and I mean years, they can be multiple in their distribution. They're no longer subtle, but they can remain subtle, but they tend to be very obvious. They run a very long course on their way to malignancy. And many studies, up to 70% of these things become cancer. And that's not unusual. In fact, you expect it. John Batsakis and others at MD Anderson in Houston wrote a very nice paper which described the transitional phases from hyperkeratosis to verrucous hyperplasia to verrucous carcinoma to squamous cell carcinoma. These are both cancers, of course, but this is the one that we have a better feel for because it doesn't have the behavioral characteristics that typical squamous carcinoma has. But they're all along the spectrum from benign to malignant. So what is the cause of proliferative verrucous leukoplakia? Well, no one knows for sure because every case is different. There does not necessarily appear to be a relationship to high risk HPV, HPV 16, HPV 18, but there are many, many other HPV subtypes which have been identified, but not consistently so. 16, 18 remain the most common oncogenic strains. Epstein-Barr virus has been looked at as an etiologic agent, but inconclusively so. Now, there are many studies that have looked at P16 and P14 alterations with some relevance, but not consistently so, and even alterations in DNA ploidy. So we can say that this tends to occur mostly in elderly women for sure. And of greater interest, many of these people do not smoke or chew tobacco or use alcohol or abuse alcohol. And PVL generally arises within the context of years of good old-fashioned leukoplakia that we just went through. Wide age range, but typically in more elderly people like me who are over 65. So the attached to gingiva, by far the most common site. HPV, controversial. The rate of malignant transformation in one particular study in the Armed Forces Institute of Pathology, all cases have malignant transformation, but that's a referral center, and we could throw that one out. But I think we can settle on somewhere between 40 and 90% is the risk of transformation. Importantly, PVL is not a microscopic diagnosis, it's a clinical diagnosis. And that is further defined by the biopsy that's to be done, where we can see this histologic continuum from totally benign to cancer. Usually starts as a single area, and they tend to spread as homogeneous alterations, but gradually over time, these alterations enlarge, they become multiple in location, they become granular and even warty or verrucous. Most of the time they involve attached gingiva. They can go beyond attached gingiva, but the primary focus tends to be attached gingiva and much less commonly on the tongue. Rapid growth with verrucous quality, that's when you begin to worry considerably. You look for areas of erosions and alterations, time to have these biopsied. If the areas that were formerly white begin to assume a red or erythroplastic quality, another danger sign. If these areas become indurated or positive on toluidine blue staining, then it's time to become much, much more aggressive from a diagnostic standpoint. Here you go. This is the data of one of my ENT colleagues at Johns Hopkins. And he came up from South Carolina to see us and his son, who had multiple white alterations on the attached gingiva with a small bridge or isthmus of normal mucosa, but fairly extensive lesions which cross the midline. Fairly homogeneous, but you can see here interproximally where the white chains are becoming thickened and even a little bit granular. Another case, unequivocally verrucous or warty, involving palatal, buccal, and attached gingiva and through the interproximal region. This was ultimately proven to be carcinoma, but clinically proliferative verrucous leukoplakia on biopsy. These are some of the chromosomal changes on chromosome 9, the P arm of chromosome number 9. And lots of different inactivations occur in various exons with deletions, gain of function changes, and so forth. And you can see these in aggressive variants of PVL versus non-PVL dysplasias. So do they affect disease progression? Yeah, probably they do. Human papillomavirus has no differential role in the development of proliferative verrucous leukoplakia versus non-proliferative. So I think we can keep the HPV question alive in our minds, but it does not have an unequivocal causality within the spectrum of oral leukoplakias. And we will hold our final opinion concerning all cases of PVL and HPV until further studies come down the turnpike. Mini chromosome maintenance 2 is one of the proteins, and there are several members of the MCM2 family, 2 through 7. And these particular proteins, in fact, are involved with maintenance of chromosomes and can affect the level of dysplasia that can result when this expression is altered. Many PVL cases show aneuploidy. And the MCM proteins, as noted here, are important in orderly DNA replication. And when the MCM proteins are altered, that DNA replication becomes faulty, and therefore the door becomes open to premalignant or malignant change. So, summarizing PVL, we don't know what causes it. There are lots of studies out there now with rather definitive and detailed molecular alterations published. The diagnostic criteria are not necessarily well established, and you look at my literature and it's all over the map. Treatment of proliferative verrucous leukoplakia, understand that recurrences are very, very common in spite of adequate excision at the time of treatment. High rate of transformation, 70% is as good a number as any. And in some series, as I said earlier, almost all cases became cancerous. And there's no consistent treatment success. Success is elusive when it comes to PVL in terms of cure. No consistent association with environmental agents, including tobacco. And its natural history versus other premalignant diseases is very different and very special because of its high rate of transformation. If you look at submucous fibrosis, lichen planus, verrucous hyperplasia, various forms of dysplasia, PVL by far has the greatest risk of transforming into cancer. By the way, Dr. Lamster and I talked about references. Many of these slides have references on the bottom. So if you really want to go after that, you can take some notes and copy these references down and follow up on them if you so choose. Okay, so let's talk about erythroplakia briefly. Not nearly as common as its white counterpart, leukoplakia, and many times leuko and erythroplakia occur together, so-called erythroleukoplakia. But in and of itself, erythroleukoplakia is far more concerning and far more dangerous. This is a red patch, cannot be clinically diagnosed as anything specific. Or you can say, yeah, it's red, it's well defined, it's kind of velvety, it's in the oral cavity, and I'm concerned about it, but I can't tell you what it is biologically. This was described initially in the genital area and the dermatology literature. The erythroplasia of Queyrat is on the penis, the penile disease. Almost all cases, like 91, 92% of oral erythroplakias have some level of dysplasia or cancer at the time of diagnosis. 8 or 9% are benign, but the vast majority you better pay attention to. The estimated incidence is relatively small, 1.2 cases per 100,000 of the population, much less common than typical white lesion, and underdiagnosed. And there are good reasons for that. We'll get into that hopefully. It's well demarcated, soft and velvety, usually not bothersome, and may be associated with adjacent leukoplakia. Here's some of the things we talk about differentially. Chronic erythematous candidiasis, one of the many forms of candida infection. Psoriasiform disease or oral psoriasis, non-specific forms of mucositis, vascular lesions and hamartomas, all of which can have a red velvety component to them, such as this. And I say, well, maybe that's from the denture. Well, I wasn't quite happy with that because if you look carefully, there are some white changes here and there. So this was biopsy here, biopsy here. We mapped it out, and 2 of the 3 lesions were significantly dysplastic, and this was all stripped off by my colleague Joe Califano when we were working together here at Hopkins. I did that. Oh, I went backwards. That's why. Here's a case of erythroleukoplakia. So red, velvety, fairly well demarcated in a bad place, a high-risk site in the ventral tongue region. And if you did a random biopsy in the red area, you could see something like this, which is not quite cancer yet, but this is severe epithelial dysplasia with many of the cytological hallmarks which make it so. Very briefly, submucous fibrosis. Yes,
can I interrupt for a second?
Sure.
I just would like you to discuss the idea of management of these lesions or these suspicious lesions, which really requires not just months, but probably years or even decades. Well, how is that in a general dentist's office? How could that be managed?
Well, I think I'm going to mention this later on, but it's an apt and appropriate question, well timed. How do you manage it? Well, you've got to identify what's going on first. Photograph the lesions. You all have clinical cameras. If you don't have one, get one. Photograph, archive them. That's number one. Documented by verbal description. get a tissue biopsy, document the biology, and store that in the patient's record. Now it's in your hands, or you may choose to refer it out, which is also fine. What do you do now when that patient comes back to you 3 months, 6 months, 12 months later, and the lesion is maybe unchanged? That doesn't mean you give them a free pass. You always must get back to that lesion. It's your responsibility to track it, describe it, compare it to the original photographs you may have taken, or any interval documentation you have had since the original biopsy. So the answer is forever, Mara, forever. As long as the patient's in your care and there's something to see once it's been documented. I hope that answers your question. Okay, so mucous fibrosis, kind of a niche condition in the US. This is when I was in the military, I spent a few years in Southeast Asia, courtesy of the US government. And I saw a lot of submucous fibrosis in my trips to India, of course, and I lived in Thailand for a couple of years. And this was very common in the native population. These folks chew betel or areca nut, and they have very, very spicy diets, all of which are thought to contribute to submucous fibrosis. You see a blanching of the mucosa. Here you can see a vertical scar band. You can see the staining from the components of the betel quid, which can include tobacco, areca, lime, and aromatics. This is what the palate looks like. Again, a minimally vascular lesion, very dense, and a loss of elasticity. I was very fortunate, and this man did not have a lot of trismus. Some patients I've seen have tremendous amounts of trismus. They just can't open. Their buccal mucosa is so scarred and so many vertical bends, they cannot open. This is what a biopsy looks like. The overlying epithelium is thinned and atrophic, and within the lamina propria and into the submucosa, you can see blanched surface areas, collagen, dense areas of collagen. This is submucous fibrosis. It's widely scattered fibroblasts, which are benign, and some early dysplastic, minimally dysplastic change. We're going to my favorite oral lichen planus. I see a lot of oral lichen planus. It is by far the most common mucosal disease that is referred to me in my oral medicine, oral pathology practice. Loads of them. So where do you find lichen planus? Take your choice. The oral cavity, the oropharynx, the larynx, the skin, the scalp, and nails. In the esophagus, a very nasty place for lichen planus, which some of my oral LP patients have. In the anogenital region, vulva, vagina, male genitalia as well. So it doesn't discriminate. It's an equal opportunities condition. Affects up to 1% of the population in some studies, but other studies show up to 5% of the population prevalence rate of LP. More in women, and I can say that from my years in practice, at least 2/3 or so of cases are in women, maybe because they take better care of themselves, but I think it's more biological than it is how they take care of themselves. Always ask about cutaneous lichen planus. Mrs. Jones, do you have any itchy areas on your leg, on the inside of your arms? Do you have any obstetric or GYN issues that require attention? Itching, burning, supposed fungal infections, vaginal candidiasis, and so forth. The average age tends to be perimenopausal, middle-aged years. And some folks have had oral lichen planus for years before they get to me, or they mention it to their dentist, or it's picked up. And there are many clinical presentations, which we'll touch upon briefly. Up to 1/3 have concomitant or concurrent skin lesions. We mentioned GYN involvement. My colleague and friend, Drory Eisen, who is a dentist dermatologist, believe it or not, defined several years ago the vulvovaginal gingival syndrome, where he was able to correlate GYN disease with gingival, severe erosive atrophic gingival lichen planus on a consistent basis. Most lichen planus patients have, 25% of lichen planus patients have oral involvement. 1/3 or so have skin lesions only, and others involve multiple sites. When lichen planus affects the gingiva, they can be discriminative. A gentleman that Ira Lamston knows very well, Dr. Ed Zegarelli, and colleagues at Columbia many years ago, defined the term desquamative gingivitis as a specific diagnosis. However, The squamative gingivitis could be lichen planus, but it could also be mucous membrane pemphigoid, pemphigus vulgaris, lupus, and other things. But nevertheless, when lichen planus involves the gingiva, it can be desquamative or peeling or shedding in nature. The lesions are generally symmetrical. The classic, as you saw earlier on, these radiated keratotic striae, that's the classic one, but there are subset variations, which we'll touch upon momentarily. And you can see classic reticular lichen planus to atrophic lesions, erosive lesions, all in the same patient at the same time. For instance, I put this montage together, classic reticular lichen planus, gingival lichen planus, and the differential diagnosis here is wide, which includes mucous membrane pemphigoid in particular, erosive lichen planus, which is atrophic, and then peripherally keratotic, and then centrally ulcerated. Very bothersome, very annoying. And that is often what gets the patient to see us. And there's the hypertrophic keratotic form, homogeneous, thickened areas, but you can also see concurrent reticular lichen planus and atrophic lesions in the same buccal mucosa. So that's the variation quickly stated. So does lichen planus go away? Yeah, in some cases, sometimes it does. The most common variant that does spontaneously resolve is the reticular variant, but only 7% or so of the erosive lesions resolve on their own. They need a help and a lot of it many times. But lichen planus can be, I wouldn't say lifelong condition, but it can be persistent for many, many decades from middle age into advanced age. Buccal mucosa, most common site of involvement, easy to diagnose. There usually the gingiva, again, has a differential, listed differential diagnoses. The tongue, especially the lateral and the ventral surface of the tongue, and less commonly so on the palate toward the gingival margin. Reticular, most common type, atrophic, and then erosive ulcerative lesions in descending order. The initial stage, the active stage of lichen planus can be relatively short, and then you evolve into the chronic variable timeline, lasting several years, and then ultimately post-onset. Post-onset LP can gradually resolve, but oftentimes severe disease will lead to scarring. And vertical scar bands can occur, can form in the buccal mucosa, and also produce a level of trismus and dysfunction. There I just said that. Resolution of inflammatory disease, usually spontaneously, but we intervene, of course, to control the inflammatory disease. You can see concurrent atrophy of the mucosa, depapillation of the tongue. Filiform and fungiform papillae oftentimes go away, either generally or in a patchy pattern of distribution. In the buccal mucosa, the lesions of the tissue can become fibrotic. I didn't mention these scar bands before now, twice. And in older cases where lots of scarring has taken place, the depth of the alveolar sulcus, the mucobuccal sulcus, can elevate, and you lose that nice little sulcus for salivary retention and so forth. And some cases show post-inflammatory pigmentation, which is generally brown, not melanotic, hemosiderin-like under the surface. Reticular LP, we've been through that. Erosive and ulcerative lichen planus with homogeneous and maybe some delicate reticular alteration. Very bothersome, usually on left, usually bilateral and symmetrical. A punch biopsy we did, intact mucosa and intact epithelium, brisk, dense lymphocytic inflammatory infiltrate, which parallels the surface, and you see these spike-like reedy alveolar ridges, or reed pegs, if you will. You see a trafficking of activated lymphocytes into the epithelium and across the basement membrane zone, and actually you see loss of the typical basal layer morphology, akin to what we see in a healing wound. Direct immunofluorescence will show fibrin deposits along the basement membrane zone. This is the epithelium, this is the lamina propria, and this is fibrin that lights up at the basement membrane. This is not specific, but highly suggestive of lichen planus in the absence of illumination of other immunoglobulins, IgG, IgA, C3. Yeah, okay. So the 800-pound gorilla. Is chronic inflammation a transformation factor? Yeah, I think it is. I think it is. Back to my evolving love for chronic inflammation. The more I read about it, I've been doing a lot of that lately. The more concerned I become with chronic inflammatory mucosal diseases. Now, you'll see the term oral lichenoid lesions, OLL. The separation of these two entities, typical lichen planus and lichenoid lesions, they are very controversial. We tend to aggregate them all under the rubric of lichen planus, but oral lichenoid lesions are a little bit different histologically and biologically, and the oral lichenoid lesions have a much higher rate of malignant transformation. These are the ones that get our patients in trouble, more so than classic lichen planus of the reticular type. So what is transformation risk? Well, any of these pre-malignant diseases that we've seen thus far have risk of transformation. I want you to pay attention to the very lowest bit of information on the slide, the Tomasetti-Vogelstein study. Christian Tomasetti and Bert Vogelstein, colleagues of mine from Johns Hopkins, a little name dropping, I guess, they published this, to me, a very important paper in Science just a few years ago, where they talked about R mutations, which help explain the transformation of any pre-malignant disease, be it oral mucosa, be it breast, be it whatever. Because we know that over time, over a lifetime, there's a gradual accumulation of genetic mutations. Tomasetti and Vogelstein describe what they called R mutations. These are random mutations which occur with every single division of stem cells. So with stem cell DNA replication, 3 mutations per stem cell division occur. Now, most of those mutations are harmless, but on occasion, they're not. And you accrue these over time. And with time, as we get older, these mutations accrue much greater significance in the formation of what? Malignant disease of one sort or another. A wonderful paper by Mahana and colleagues in Head Neck in 2009, still to my mind a classic paper, showed a transformation rate of oral pre-malignant disease of 12.1% in almost 1,000 patients. I asked a question before about excision. How do you treat them? Well, you excise them, but excision, even successful excision, doesn't necessarily reduce the mean rate of transformation. So the mean transformation rate is not necessarily eliminated by excision. Another answer to the question posed, how closely do you follow your patients and for how long? To me, forever. Be once every 6 months, once every 4 months, depending upon the nature of the previously described pathology. This is one of my favorite pictures. This is a picture of a skunk cabbage flower in the early spring up in Harriman Park, New York.
Before you go on, one of the advantages of being the moderator is I get to ask questions before anyone else. And I just want to remind everyone to please type your questions into the chat box. We should have time at the end to answer some questions. I have a couple I'd like to interrupt you with now. The first is, if a patient presents with lichen planus in more than one location, in addition to the oral cavity, but outside of the oral cavity, does that foretell a more severe, worse outcome in the patient who just presents with the oral form of disease?
Well, it's a very interesting question. I don't know if there's any single answer that I can offer you that's authoritative, but I think that what we can say is that lichen planus is an immune-mediated disease. And we know with one kind of malignancy or another, be it another distant squamous carcinoma or another cancer, the T cell repertoire is changed, is shifted. So I think there is a relationship. I've seen oral lichen planus be basically a factor that is, the word I'm looking for is a paraneoplastic effect of malignant disease. I've seen it arise in folks that have had their malignant disease treated and oral lichen planus emerges. So lichen planus is a very heterogeneous disease, really, when you come down to it, that is mediated by T cells that are either switched on or changed in the overall behavior profile. Now, if that's not gobbledygook, nothing is.
Yeah, that sort of leads to the second question.
Go ahead.
And again, you're influenced by what you see clinically. And I remember a case, and you and I discussed this briefly beforehand. I remember seeing a case of a woman that I was following with a sort of aggressive form of lichen planus, but it really became quite aggressive and became quite severe. And I recall that just a few months later, she was diagnosed with a genital malignancy. And the whole idea that a change in characteristic of lichen planus, is that indicative of any other condition, or is it just sort of a random event?
Well, I don't know if it's so random. I don't think it's just happenstance. I think there is biology underlying that. I know that many of my folks with paraneoplastic disease will have oral lichenoid or lichen planus lesions as an expression of their paraneoplasia. So the answer is yes, in a not so loose context. I think there's good biology to explain that happening.
Great, thank you. Again, I want to remind everyone to please type your questions into the chat box. We should be able to get to those at the end of Dr. Sciubba's lecture. Sure.
Yes. Okay. Let's move on to cancer. Now we went over these numbers before when I introduced the subject, and I think the numbers generally hold. 3 to 5% of cases, 50,000 cases a year, almost 12,000 deaths every year, classically and typically. Most oral cancer arises from previously non-invasive precursors that progress to cancer. Now, the diagnosed oral cavity cancers these days, 40% are diagnosed early stage 1, stage 2 disease. But stage 3, stage 4 are the ones that we really are worried about, which I'll show you in a few minutes. And that diagnosis, we don't often see metastatic disease. And when we do, this is usually late stage 3, stage 4 disease, be locally metastatic or distantly so. So 40% T1, T2. T1 cancers are defined as measuring up to 2.0 cm. T2 disease, 2 to 4 cm. 4 to 6, now you're into T3 disease. That's advanced disease, and you get up stage right off the bat to stage 3 at least. Large primary tumors invade adjacent structures, muscle, bone. And of course, they can metastasize distantly, and they like to go to lung predominantly, but they can go anywhere they want. Anterior floor of mouth, found in a routine oral exam. Asymptomatic, not bothersome, but look how thickened, how heaped up the mucosa is, and areas here which are thinned and atrophic, and even around here, and then definitely leukoplakia right here as well. So this is anterior oral floor, crosses the midline. So it presents a very challenging question of how do you manage this effectively and do a cancer operation? Can you preserve the jaw? Do you do an anterior resection? How do you reconstruct? All of these are considerations in significant T2, at least disease, maybe early T3. Elevated, nodular, white, red, and on the lateral soft palate extending into the oropharynx and even onto the soft palate. This is all cancer, really. This is the obvious tumorous phase, but this is all this at least significant and severe dysplasia. The patient I saw not all that long ago, this fellow came to see me, sent by his general dentist. He said, I never seen anything quite like that on the lingual frenum. He didn't wear a denture, didn't have any tongue habits, and one thing I always do, and you should be doing as well with your gloved fingers, is just feel these things. This was nodular, it was firm, it was asymptomatic, and I did not like it. So I removed maybe half of it. It could have been easily removed in its entirety, but since I was suspicious, I wanted to leave something behind if further, more extensive surgery was necessary. And of course it was, because this is an early stage 1, T1 squamous carcinoma with negative lymph nodes. So he did very well with a limited surgery. He had a limited anterior oral floor resection, and he's absolutely fine a few years later. This fellow has survived his nagging wife. I remember this very well, and she nagged him for good reason, because he always refused to get his mouth looked at. And when he finally did come in, this is what he showed me. Nodular, thickened, heterogeneous, red-white lesion involving the attached gingiva extending into the alveolar sulcus. This is a good T2. And it invaded bone. No surprise. This is, you want to call this erythroplakia, that's fine. But histologically, it was cancer. Cancer here, cancer here. So this is a wide field of oral squamous carcinoma. This is a T3 primary. This is a case we saw just recently, and I think it's on the web page for this particular presentation. Oral floor, lingual sulcus, elevated, verrucous to ulcerated, thickened, indurated, red and white. Cancer, can't be anything else unless I'm dead wrong. And this is just, I'll show you two cases of squamous carcinoma. Here you can see overlying dysplastic epithelium, and you can see drop off of these dysplastic dyskeratotic cells into the lamina propria. And sometimes this happens. This is a lymph node, a section of lymph node. Here you see the edge of a lymphoid follicle, and here you can see the balance of this node replaced by squamous carcinoma. Once this makes itself evident, the patient has bought themselves radiation therapy and a neck dissection. Stage three disease with a correspondingly poorer survival rate compared to stage 1 and 2, obviously. So the key, early detection. Sometimes early lesions are not going to tell you how significant they might be. So innocent lesions can be often left to progress. We'll come back in 3 months, Mrs. Jones, come back in 6 months. Didn't take a picture, didn't describe it. The patient missed her 6-month appointment, shows up 18 months later. Now she's got a significant tumor. That happens all the time. So when classic features of oral cancer make themselves evident, nodularity, fixation, size, bulkiness, that's later stage disease. Now you're talking about a T3, probably 4 centimeters or more. And now you've got a big operation on your hands and significant post-treatment disability and toxicity. So 5-year survival rates, you go from localized disease, or 80% or so survival at 5, to less than 40% survival at stage 4 disease. And in the cases where you cannot find a primary, and only is by virtue of the demonstration of metastatic disease, less than half survive. So 5-year survival up to 98, all races, 56% 5-year survival. The differential 59 to 53% are whites versus African Americans, typical. Most arise from surface epithelium from a non-invasive precursor. We talked about some of the genetic alterations that occur. Fortunately, most can be defined in their early stages, and therefore cure is in the ballpark, is a very real consideration and something you talk to your patient about and be optimistic. How often do you see metastatic disease in an early stage? Not very common. And of course, back to this question again, what's the relationship to chronic inflammation and the possibility of an evolving cancer? I think there is that relationship, etiologically and so forth. Now, when you begin to look at specific chromosomal and genetic studies, losses at these many loci, 3p, 18p, 17p, these are all very important alterations. You see losses, you see gains, and importantly, these genetic instabilities go well beyond what you can see with your eye and where you can see that the surgeon ended their treatment. The changes are generally invisible. And this was defined in 1993 by a fellow named Dan Lee Slaughter, who, a very quick story, Dan Lee Slaughter came up with the field cancerization study hypothesis. And I remember he was at the University of Illinois where I did my postgrad work and my fellowship and all that stuff. And I would remember walking down the hall and I said, wow, Dr. Slaughter walked these very same halls 20 years ago, which is true. So Dan Lee Slaughter defined the notion of field cancerization, which basically is extension of these now genetic and chromosomal alterations well beyond what you can see down the microscope, and therefore seed or be the source of further cancer development. The percentage of new oral cavity oropharynx cancers, 22.9% of all. Estimated deaths, almost 10,000. Percentage of cancer deaths, 2%, less than 2%. And overall, here's where I already said before, overall 5-year survival, 50%. Yeah, but looking at the more recent data from the Sciubba database, up to 64% 5-year survival overall. Now remember, we're folding in oropharynx into this statistic. Oropharynx primaries, if they are HPV-16 positive, have a much better 5-year survival rate. So the numbers are a little bit less than firm, but clearly our overall survival data, even for oral cavity cancer, leaving out oropharynx, they're improving significantly and approaching 60%. But you folded oropharynx primaries, it's certainly over 64%, because they carry up to 80% 5-year survival if it's an HPV-16 positive oropharynx primary. So the molecular progression model, defined by Califano at Hopkins and Jim Rocco and other folks in New England, they described and proved a stepwise series of changes, both genetic and epigenetic in origin, within the oral epithelium. And because of those changes, they were able to demonstrate biochemical messenger changes and promotosynthesis alterations and affecting cellular activity, like this. If you look at the deletions and loss of heterozygosity along this spectrum from the initial genetic insult, after accruing many, many chromosomal changes over the years, you ultimately wind up with a whole array of genetic mutations, which in fact lead to proliferation and further mutations. Epidermal growth factor receptor alteration is very, very important, because we now have drugs that can go after the EGFR focus and improve response to chemotherapy. So that's targeted therapy based upon now molecular analysis that we can do today that we couldn't do 10 years ago. This is the paper that Joe Califano senior authored, taking, theoretically at least, benign mucosa, dysplastic, in situ, dysplasia, and carcinoma and deep carcinomas. And you can see the histological progression, and they match that with the chromosomal and genetic alterations, losses of heterozygosity, all along that chromosomal aberrational sequence. These two cases show the same microscopic changes, from maybe some hyperplasia here to mild dysplasia with changes restricted to the lower third of the epithelium, moderate dysplasia, maybe even minimal severe dysplasia, bottom to top, and now invasive cancer beyond the basement membrane. All this spectrum can be tied back to or related back to losses of heterozygosity in certain chromosomal loci. A patient of mine at Hopkins some years ago was showing Dr. Califano this. I said, look at that. And he said, wow, this is terrific. Wow. So let's do this. Dr. Califano did, and I was eighth in line, worked on this study where we mapped out the various alterations on the tongue and looked at the changes in the chromosomal alteration and the genetic alterations in these various loci, losses of heterozygosity and other mutations, depending upon where you sampled on this very badly involved tongue. So what do we know? 350,000 cases a year across the world, increasing incidences in developing countries, increased risk of second primaries in the upper aerodigestive tract. This is not a new phenomenon, new finding. Base of tongue, larynx, esophagus, all of these locations have an increased risk of developing squamous cancers in addition to oral cavity cancer. And most cases are associated with precursor lesions. The challenge, which of those cases has a true malignant potential? And that's where the rub is. Can you predict? We're getting better at it. I think we've been through this. No sense beating you over the head with it. Now we have said, and we've touched upon, the cancer survival rates over the past few years have begun to improve unequivocally. Better surgeries, better reconstructions, much improved adjuvant radiation therapy and chemo. We're moving away ultimately, and we will, from cytotoxic therapy now to more genetically targeted, more molecularly targeted therapies with growth factor identifications and other stops along the way in the neoplastic tree. The alarming trends, we see increases in cancer in the young, that is under 40. White females seem to be showing an increased incidence for some reason, many of whom do not have risk factors, including HPV, smoking, drinking, whatever. Generally speaking, poor prognosis in African American males, probably because of societal factors, or neglect, or not getting to the doctor on time, or all of the above. So most cancers arise from surface epithelium. We've shown you the progressive genetic alterations which lead to cancer. 40% of diagnosed oral cancers are found at an early stage, thankfully. And metastatic disease early on is uncommon. That's a duplicate slide, but it doesn't hurt to repeat that one. Now, traditionally, field cancerization, of course, is real since the 1950s when Slaughter described that. But today, we're able to show why field cancerization is what it is, because we've demonstrated unequivocally definitive changes at the molecular level. And looking at some of the work that Jonathan Garlick has done over the years, he was able to show lateral spread of these altered cells along the epithelium. So clonal population doesn't just go top to bottom, it goes left to right too. So these altered cells expand their field, as it were, go well beyond what you can see with your eye and what you can detect in the operating room when you have a scalpel in your hand. These are the allelic imbalances. There are loads of them. I don't expect you to remember them. I certainly don't. And we are able to demonstrate unequivocally now and legitimately various levels of ploidy alterations. Can we predict the course of premalignancy? Maybe. There are some people say that we can, and there are some specific markers. CD44 is one of them that may have a role in that. Molecular markers, we have tissue-based markers now and blood-based markers, as well as salivary markers, so-called liquid biopsies. And you pick up any cancer journal worth its salt, and you'll be able to see what is being analyzed and what they're looking for in these various fluids that they're harvesting from the patient: saliva, blood, washings, whatever, and looking for pieces of DNA, fragments of DNA, proteasomes, and so forth, all of which have malignant origins. Okay, so this is the cell cycle, and these are all of the components that affect the cell cycle, focusing here on the maintenance gene, the p53 gene, which is terribly important. And so the p53 and all of the other pathways and markers that affect it. So here you can see how all of these pathways and the networks that they form are incredibly complicated, from the cell surface down through the nuclear envelope, ultimately getting to gene dysregulation and ultimately leading to uncontrolled cell proliferation, all by virtue of altered signal transductions. Serum and saliva look at metabolic and transcriptome analyses by virtue of mass spectrometry. David Wong's people and others have published on this. Foundation One, which is used every day now, you can send your tissue to Foundation One in Boston, and they'll be able to tell you which genes are involved, and they can maybe at times identify what they call targetable genes. If they can identify a targetable gene or two in a cancer, there are therefore chemotherapeutic agents which can go directly to those places and destroy them. So sequencing, translocations, insertions, substitutions, copy number alterations, all of which are possible now by rather sophisticated sequencing. These are used every day in melanoma, ovarian cancer, breast cancer all the time, prostate cancer, non-small cell lung cancer, all can be detected by altered sequences. And various biomarkers, epidermal growth factor, BRAF 600E, that's commonly seen in melanoma, among other things, HER2 amplification, all of which, this is in breast mostly, all of which have therapeutic applications, hence the term targeted therapy. And I've just read something looking at the future where significant breast cancers are going to go away. And with better analyses and better targeting and better chemotherapeutic agents, they will be able to go after these very specifically identified alterations and treat cancers of various types, including lung and breast in particular. So take-home points. Appreciate the range of premalignancies, which are more likely to transform, PVL among them. Understanding what PVL is and its high risk of transformation. separate non-leukoplakias, white lesions, from leukoplakias, and discuss the importance of early cancer detection and survival. We've been through very quickly the molecular and genetic progressions that lead to the development and actually spread of oral squamous cell carcinoma. Clinical diagnostics from the good old-fashioned biopsy to liquid biopsies to spectrographic analyses, and importantly to the everyday clinician, like people like me, and hopefully many of you, documentation, documentation, documentation. Write down what you see, describe it in detail, take a picture. Being worth at least 1,000 words, it's important. I consult my images all the time with my follow-up patients, all the time. And if the patients need to be sent to for treatment to an oncology center, I send my photographs in a JPEG format to the surgeons. I know they'll know exactly what I'm talking about, and not that they need to see because they know, but I want to show them how this all arose and what the progression was. And patients have to share the burden of follow-up. You're not going to go to their home and pick them up and drive them to your office. They've got to be told very specifically they're expected to be back to see you, change your lifestyle, get away from smoking, stop it, occasional alcohol, if any, and change your overall living preferences if you got fatal disease or near fatal disease. Self-serving information, yes, Dr. Ira asked me to, what are some good places to go for primary and secondary level of information. Our textbook, Joe Rigasi, myself, and Richard Jordan. Our book is in the 7th and probably final edition, I think. The very good book by Brad Neville and Doug Dam and others, both of which are published by Elsevier. So these two textbooks, I think, for the American dental market are the two best books out there with very clinically directed messages, good illustrations, and good narratives. And this little bridge in Soamesville, Maine, the bridge to success. Go from point A to point B and gather information all along the way, make you a better clinician and a better doctor. Thank you for listening. I'll take any questions you may have, Ira.
Well, first off, Jim, I want to thank you, and I'm sure the attendees want to thank you for what has been an incredible hour. The amount of information provided, succinctly, so beautifully illustrated, both histologically and also clinically, I think is remarkable. It speaks to how active you've been as a clinician and as a researcher.
Realizing that I put a lot of information out there, very, very quickly stated. Hopefully, at least whet the appetite of folks and get into some of those references I mentioned in the slides. If people wanted to contact you or me, I'd be glad to supply some of the references that I've stated within this presentation.
Great. Well, we have some actually terrific questions, many of them clinically oriented. So let me start with a couple. I'll try to group them in terms of categories. I don't know. Okay. It's possible they came in at sort of different times. There was a question about some of the devices that have been marketed for identification of oral lesions and oral cancer, and the one that was mentioned, the question was the Veloscope.
Right.
You want to comment on those devices and the usefulness, their accuracy, etc.
Well, I think they have use. Clearly, there's a significant margin of error for the Veloscope and other optical devices. They're getting better. Many of these optical devices and spectrographic analyses are improving year by year. So I would not necessarily poo-poo them by any means. I'm going to give you a perfect example. I'm reviewing a case now for someone who had abnormal Veloscope findings. The dentist noted that it was an abnormal finding. He never told the patient. She never went back. Guess what? She was treated at Memorial Sloan Kettering in New York City for bilateral neck mets, and she lost almost all of her tongue because it was never acted upon. So the Veloscope was positive. The biopsy ultimately was done like 3 years later where advanced disease was present. But Veloscope alterations was the first indication, which then would have mandated a biopsy right at that time. It wasn't done. So yes, yes, Toluidine blue has a role to play. The Veloscope and similar light devices have a role to play, but they're not nearly, they have significant sensitivity, specificity pattern, which is not ideal. But then again, many oral biopsies are not ideal all by themselves. So a lot of things go into getting an accurate presentation, biologically and clinically.
Those devices are characterized as more, a greater number of false positive findings.
Yes, yes. Remember, they're screening devices. They're not diagnostic. They're screening devices. But it gives the clinician something to go on if they're not exactly 100% normal.
So another related question was that we were asked to comment on the brush biopsy technique and the usefulness of that technique.
I had the pleasure of co-authoring or senior authoring that paper in 1999 in JADA. And we were criticized by the fact that we did not biopsy all of the cases that we harvested across the country from various institutions. However, the oral brush biopsy to me still has relevance. It still has importance because you're harvesting cells when it's done properly, getting these abnormal cells on a slide, just like the gynecologist does with their pap smear, and reviewing them, at least, well, you know, they're abnormal cells here. We've got to do something about it. So I think there's a role for it to play. The specificity and the sensitivity is relatively good in most of the papers you read, but by no means all. So there's a role for it. The gold standard remains, even to this day, the biopsy, be it a punch biopsy or scalpel biopsy, in my opinion.
Great. Comment on the association between either prescription or OTC drugs and lichenoid reactions, and how often does that present a complication to the differential?
The answer is, in many of the patients I see, most of whom are middle-aged and beyond, are already on a host of medications. Some of those folks have lichen planus by visual examination. And histologically, they've got lichen planus. Say, well, how much of that is due to lisinopril? How much of this is due to their hypoglycemic agents and whatever? So what you can do, if these patients are only taking 1 or 2 different drugs, you can maybe mix and match with the help of their family doctor, of course, and see if there's a change in their presentation profile. But I will tell you, my 44 years of experience or thereabouts, I have never had good, consistent results with changing of medications and getting a corresponding improvement of their lichen planus. I treat the lichen planus whether they're on antihypertensives like lisinopril and others or not. And I use the response to help me, and they'll stay on their medications.
Great. A question that I think really delves into some of the long-term management is the question of how often should a PVL lesion be biopsied? I don't know if you'd be able to characterize that in general, but maybe you could just feel that.
Yeah, I think you've got to use your clinical judgment as to how often you go back in there. But I think one thing I would do early on, if they've got a PVL lesion that crosses the midline, involves 3, 4, 5, 6 teeth in succession, I would take at least 3 or 4 biopsies at the first visit. I try to map it out and get a sense of what's going on there pathologically. If they're all totally benign, fine. Then you have the chance, you have the luxury of following these folks at a maybe every 3-month level. If any of those biopsies are proven to be positive, then you're left with how far should I have the surgeon go in treating this? Do you take them all off? Do you have them heal by secondary intention? Do you take them all off with a margin and put a skin graft in place? This is it's a good question, but it's a difficult question to answer authoritatively. Depends upon the health of the patient, the whims of the patient, their preferences, and of course what the surgeon's preferences are as well, and experience.
I just want to make sure you need a sip of water because
I'm okay. Yeah.
Okay.
Yeah. Thanks.
Okay. So more questions. And I think this is a very practical question. And a patient who presents with lichen planus or leukoplakia, are there any oral hygiene products that you would suggest the patient should avoid? And we can start with the alcohol-containing mouth rinses and go from there.
You know, and I know for many years, whether or not alcohol-containing mouthwashes have a role, or should they be removed, should they be eliminated? And I think many of the drug companies that produce mouthwashes have listened, and they are producing an array of alcohol-free mouthwashes. Fine, by all means. What's the data? Some of it's a little bit weak, but I think if you have a preference, avoid alcohol-containing mouthwashes. Hygiene, Clearly, it's important because it carries with it the risk of inflammatory disease if hygiene isn't good. So if it gets to elimination of inflammatory disease, that's one thing. And eliminate the possibility of alcohol as having a role here. And there are many studies that say alcohol has no role at all. So I don't know the right answer to that. But I would err on the side of safety, eliminate the alcohol containing mouthwash. Simple.
So another specifically clinically relevant question. I think this is a good one.
Mhm.
What do you do if a patient refuses a biopsy? How do you manage that particular situation?
You write a very detailed note in the chart indicating that Mrs. Jones has refused to allow an incisional biopsy based upon suspicious clinical circumstances, which I strongly advised her to do. She refuses. Mrs. Jones signs it, dates it. It has to be more formal than that. But that's the patient. The patient has to bear that responsibility. And even when they come back 2-3 months later, you try to sell it to them again. It's like getting COVID vaccinations. Leave that one alone.
Again, sticking with the clinical management, an association between diabetes mellitus and squamous cell, oral squamous cell cancer.
Loose at best. I can't say there's a direct dotted line, a direct relationship. No, I don't think so. Other than an increase in inflammatory gingival disease, which you know very well from your time at Stony Brook and Larry Golub's work and so on. But I think the strict, well-managed diabetes doesn't really have, assuming an absence of other risk behaviors, should not adversely affect the cancer development or pre-cancer evolving to cancer.
There were a number of questions about HPV and HPV vaccine. So let's take one that I think is direct. Do you find that, or have papers, have research looked at the occurrence of HPV-associated oral cancer with vaccine status?
Yeah.
In other words, has there been vaccination?
HPV 16, 18, Gardasil, now there's a nonavalent 9 virus combination in Gardasil, for instance, not just 16, 18 anymore. I think we have to allow some time to go by and have enough people vaccinated with nonavalent vaccine to see if there's any change in oral cavity cancer. Clearly, there's going to be a change in oral pharynx cancer, base of tongue, tonsil, upper air digestive tract. There will be definitely a change for the better. Oral cavity cancer, those cancers are occurring anterior to the circumvallate papillae and the retromolar trigone, heart-soft palate junction. No one has convincingly proven that HPV has a causative role, and you can find papers to support your point. But in general, the conventional wisdom is that HPV does not seem to have a direct relationship to oral cavity cancer, but definitely oral pharyngeal cancer, yes.
Just a few more here. The question about, and I think it's, again, a good one, but specific patient complaints regarding the mucosal lesions, either non-malignant, pre-malignant, or frank malignancy. You talked about, for example, submucous fibrosis and the idea that the opening might be restricted. But yes. What about some of the others? And I'm not really here talking about the squamative lesions.
So, Ari, we're saying that the other lesions, such as, in addition to submucous fibrosis, lichen planus, various forms of leukoplakia, is that what you mean? And the relationship to cancer evolution?
Right.
Is that the question?
And even if you can carry this over to a patient who presents with a frank cancer.
With a tongue cancer.
Yeah, a frank cancer. Will they have complaints? Will they be symptomatic?
Oh, not necessarily. Oh no. Many times we find cancers that patients they're discovered incidentally, or they're discovered in the dental office. They're referred to me, and they remain asymptomatic throughout. So they're not always bothersome, and they may arise in erosive and ulcerative lichen planus, for instance, which the lichen planus may be symptomatic, but sometimes the cancers are not. So don't wait for cancers to become symptomatic before you do engage in any kind of action. If it's questionable, refer them out or treat them.
I'm sorry.
It's okay.
We also had questions about the referral process. And I know you and I spoke about that in preparation for this this webinar. The question is, and again, it depends upon circumstance and location, but is it the dermatologist? Is it the oral pathologist? Is it the oral medicine specialist? Is it the dental school? What are your suggestions?
To keep it in the dental family for the moment, clearly the general dentist, as a rule, will see something that's not typical, not normal. Now, what are some of the actions? Well, I don't know what that is. I'm going to send it to Dr. X, who knows a lot more about this than I do. Fine. Or, there's something here that I'm not comfortable with. Let me at least do a biopsy and see if there's anything that demands attention. And if it does demand attention, where do you go with it? For me, my course of action, if it's malignant disease, I'll generally, but not always, send it to a head and neck surgeon. My colleagues at the University of Maryland, they're double degree people that treat cancers, and they're very good at it. Bob Ord and others, and Josh Lubeck and so forth, just to name a few folks. And there are folks anywhere in any big city in this country. You'll get dental providers, people with dental backgrounds and an MD degree that are head and neck surgeons, and that's fine. Dermatologists, some are very good at oral mucosal disease, some are less than terrific, and some are less than comfortable with it, and they'll refer to others who know a lot more about it.
And the last question, in terms of the diagnostic potential or possibilities on the horizon, what do you think will ultimately come down to being available to the clinician who would like to use either a screening tool or more of a frank diagnostic tool in their office?
Well, clearly, if you look at some of these studies now that are being done at looking at genomics, metabolomics, transcriptome analyses, those are going on right now as we speak, some of which are being used on a day-to-day basis, as Foundation One in particular. At our tumor board, our oncologist will say, well, I'm sending a specimen up to Foundation One because I want to see if we can use an EGFR inhibitor to make this cancer better and maybe devise a better treatment plan. So I think we will ultimately get to the point where tissue can be submitted or maybe for routine studies, of course, but the balance of that tissue can be molecularly analyzed and genetically analyzed to see what those changes might be and support the diagnosis, but also support the type of treatment that can be given in the absence of radical surgery, perhaps.
Well, I'm gonna stop with the questions because I think we've had an amazingly full, almost hour and a half. First, I'd like to thank the audience who has been very attentive, and you can see that or I can see that by the excellent questions that were presented. And of course, I'd like to thank Dr. James Sciubba, who gave us an outstanding presentation. In fact, the finest I've heard on this topic ever. And it was great to have you with us tonight, Jim. Thank you.
Thanks, Sarah. Much appreciated. Thanks for the invitation. Thank you all for tuning in and hopefully coming away with something on the bridge to success.
Good night to everyone.
Good night, everyone. Thanks, Sarah.
Thank you so much for sharing your experience and your expertise with us. The webinar recording will be posted online in the next 48 hours. You'll receive an email notification with the link to the recording. Please note that only by attending a live webinar will you earn an interactive CE credit. Further questions may be submitted directly on the website on the course page under the Ask the Expert tab, and our experts will be sure to get back to you as soon as possible. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERB and AGD PACE CE credits. We would also like to thank you for your interest and your participation. Please keep an eye out for our growing schedule of online courses. Thanks again, and all the best.